Hello, everyone, and welcome to our podcast today. My name is Uveka Rangappa, and I'm so thrilled to be a part of this conversation. I know we are talking about an illness, but it is so important because there are so many people out there who need to be a part of this conversation. Today, we are talking about inflammatory bowel disease, or IBD, as it is commonly known. I'm going to have to refer to my notes because there's a lot of medical terms here. So we are talking about IBD. We're going to be talking about, more importantly, mucosal healing, which is vital to managing and living with this disease. We're also going to be talking about how important it is to have a very good relationship with your doctor who is helping you out with this, and communication with your doctor, and knowing the right questions and the right conversations to have with your doctor as well. Joining us today is Dr. Thania Kahn. She's a gastroenterologist who works closely with people living with IBD and learning to manage this. She brings a powerful personal perspective, bringing in her patient, Nico Dhevnanan, and he's amazing, and he's going to be sharing his journey with us and telling us what it is like living with IBD and how this journey actually began for him. And talking about IBD today, we're talking about two main chronic conditions as well: Crohn's disease and ulcerative colitis. And these are long-term conditions that affect the digestive system and can have a huge impact on your daily life. Actually, it's quite life-changing. So let's welcome our guests, Dr. Thania Kahn and Nico Dhevnanan. Thank you very much for joining us today.
Thank you.
Thanks for having us.
Dr. Kahn, let's start with you and the very basics. What is IBD, and what is the difference between IBD and something most of us know about, which is IBS, which I actually suffer from?
So I'm very glad you asked this question. So both, so you mentioned inflammatory bowel disease, or IBD, and irritable bowel syndrome, or IBS. So you can see why they can be confusing. They've got very similar acronyms, but very different disorders. So both of them are digestive disorders. They have some overlapping symptoms. They can both present with abdominal pain, change in bowel actions, bloating, some other gut symptoms as well.
Yeah.
So very similar presentation sometimes. The big difference is that inflammatory bowel disease, IBD, as you mentioned, your Crohn's disease and your ulcerative colitis, this is a chronic autoimmune inflammatory disorder of the digestive system. So there is disease in the gut. There's inflammation, which can cause damage subsequently long term. Whereas irritable bowel syndrome, it's a disorder. It's grouped under the disorders called what we call functional disorders, or functional gastrointestinal disorders. So this is a group of diseases which have digestive symptoms such as, again, abdominal pain, a change in bowel actions from diarrhea, constipation, or both, bloating. However, there isn't a structural or biochemical or anatomical pathology that we pick up. So it's thought more to be related to disruptions in the complex interaction between the gut and brain. You've heard about the whole gut-brain axis.
Yes.
So it's thought to be due to changes in motility of the gut, a hypersensitivity of the gut, and highly related to psychological factors such as stress, anxiety, trauma, lots of other stipulated causes such as changes in the microbiome, medications, etc. So that's your irritable bowel syndrome. As we said, it's a functional disorder.
And I know all about it, yes.
Very common. We're seeing more and more, and I think that's a podcast on its own.
Yes.
But inflammatory bowel disease, as we said, the two main entities, Crohn's disease and ulcerative colitis. So they are both chronic inflammatory conditions of the gut. They're thought to have an autoimmune basis. So in essence, the body's immune system mistakenly attacks itself, which causes a hypersensitive inflammatory cascade, which leads to damage to the gut. So if you just give you a brief difference between the two, they're two different entities. They do have some overlapping features. So ulcerative colitis usually presents with bloody diarrhea, can also have abdominal cramps. And it affects the colon. It can affect varying degrees of the colon, from just the bottom part, the rectum, to the whole colon. So as I said, different severities, different extents, but mainly it does just affect the colon. And it's a continuous inflammation. So this is in contrast to your Crohn's disease, which can affect any part of your digestive system from the mouth to the anus. So both small and large bowel, and more often the last part of the small bowel. Also, just in contrast to ulcerative colitis, Crohn's disease has got a patchy inflammation. So those are the two main differences. But in essence, as I said, so inflammatory bowel disease, they are chronic or long-term diseases that patients live with. It's chronic inflammation of the gut, which can lead subsequently to damage, which can be reversible or not.
I cannot imagine what you're going through after listening to Dr. Kahn there and how she's explained this. So tell us what happened. What happened that at that point where you realized that you needed to go and get help? What was going on with you?
Yeah, it was kind of a whirlwind. It was a random Monday. We just got home from work, and I just started feeling extremely bloated and had no idea what was going on. And this kind of went on for about 3 days, which was very irregular for me. It's not something I'm used to, or, said, oh, this is normal, it's going to go away. And I went to a GP, and my GP was like, no, you've got a peptic ulcer, you'll be fine, go and take certain medications and go home. But 3 days later, it just kept getting worse and worse because I started experiencing major pain in the abdominal area. And my wife actually kind of forced me, and she's like, no, you're going to get in the car, and we're going to go to the hospital, and we're going to go run some tests. And we did that, and my diagnosis was all over the place. So we went to hospital, we got some blood work done, and they were like, no, you actually have pancreatitis. So I was like, ooh, what's that? And they started going down the explanation of what this is, and I was like, okay, can I survive this? Is it anything serious? They're like, yeah, you'll be fine. You just got to stop eating, and your lipase levels at the time was like extremely high, like 1,200 or something. Couple days later, still going through the same thing, got discharged. 2 days later, crazy abdominal pain, and then went in for a colonoscopy, and kind of figured out it's more or less in line with either colitis or IBD. And from there, it was a whirlwind of emotions. It was like very confusing because I had no idea what this was.
Yeah.
And where I was initially at, they had no idea what to do with it, basically. So for the first 2 to 3 weeks of my initial diagnosis, I had 3 different diagnoses at the time. Gosh. So we didn't know what was happening, like no idea. And I didn't have any idea what was happening because my doctor at the time was like, you've just got colitis, you'll be fine.
You've just got colitis?
I've just got colitis. And this was after my colonoscopy.
Gosh.
And it's like, you've got colitis, I'm going to send you a script and you're going to take some medications. And I was like, okay, cool. 4 days later with that medication, I actually felt like I'm getting worse because the pain was, I can't explain it. There's no words for it. So we go back, and the doctor at the time is like, yeah, well, we're just going to do pain management for now. We hope it's going to get better, which then escalated. And, long story short, I found myself sitting on a bed opposite Dr. Kahn, and that's when things changed. But it was really insane because up until the point where I got moved, we were just on pain management, and I hadn't eaten for almost 2 weeks.
Goodness. I
was on pain medication, and I was basically just surviving on injections every 4 hours in my arms, no food. Started losing weight, and it was a nightmare.
So I was just going to say, that's the word nightmare popped into my head. And other than that Monday where everything just hit you at the same time, you hadn't had any symptoms like the doc had been describing before this?
No. I lived a fairly healthy lifestyle. I was a gym goer, went to gym 5 days a week, loved running. We were running twice a week, so I took care of myself. I loved the way I physically looked. So I always looked out for my body and watched what I put in and out. And it was, again, there was no symptoms leading up to this. I was fine the morning I woke up. The Sunday before this happened, we had a braai. I just ate the normal stuff you'd normally eat at a braai, and woke up the Monday, went to work. I went to go and buy my wife a car that same day. So we went to get my wife a car, and then I was perfectly fine signing paperwork. There was literally nothing wrong with me, and I hadn't eaten for that day though. When we got home, my wife made us burgers, and I ate the first one, and I just felt something is wrong. I
was just thinking maybe it was the amount that you had to pay for the car that brought on the pain. Was there a moment where you thought, what have I done? I just bought a car. That's a pain in my stomach.
Well, I think anyone who's signing papers for the next 6 years would feel that way. It's like a financial commitment, like, gosh, maybe it's the stress or whatever. But to be honest, even during the process, it was a happy moment because she's finally getting her car, and it made our current situation with our family, it just made our lives a lot more easier, so we needed it. And then that Monday, we get home, we get the car. Within an hour of getting home, she makes dinner, sitting down, having a burger, and I just feel something is not right. Yeah.
And the rest is why we're
And
here
the rest
now.
is history, and that's why we're here.
Doc, I just want to know from you, this illness, IBD, is it something that is genetic? I mean, it is chronic. Is it something that can be passed on? Is there any idea as to, causes?
So, inflammatory bowel disease, we don't know exactly what the cause is, but, recently we are finding out more about it. It usually, you can see it as a constellation of a genetic predisposition, that's what we'd called it, plus environmental factors, some other risk factors, and then possible triggers. So with regard to the genetic question, so yes, it is more common in parents, offspring of parents with inflammatory bowel disease. So if a parent has IBD, Crohn's disease, or ulcerative colitis, the offspring would probably have a fourfold increase risk. If both parents have IBD, probably about a 14 to 16-fold increased risk. So that's the genetic predisposition. Various environmental factors have also been thought to play a part. So diet, your microbiome.
Because he was so healthy.
I know. So, I think it's important for patients to know it's not your fault, number one, and there's nothing you did wrong. As we said, and Nico doesn't have any family history of inflammatory bowel disease. Also, we'll chat more, but he doesn't have the typical presentation.
I was just going to say he didn't have the
typical
symptoms. It just hit him out of nowhere.
So we said genetics can play a part. And then, they've looked at various environmental factors such as smoking, diet, rural versus urban lifestyle, early exposure to antibiotics, even mode of delivery. So it's kind of an interplay, as I said, of a genetic predisposition, various environmental factors, and then certain risk factors such as smoking, for example. So Nico didn't have the typical presentation. So, a typical presentation of patients with IBD. So with ulcerative colitis, it's usually frank bloody diarrhea. Whereas patients with Crohn's disease, it's more abdominal cramps with diarrhea. Those are the main symptoms.
Oh wow. Okay. So it actually is. It's quite scary because now you actually don't know. And because is it something that's quite rare? Is it rare? Is it becoming more common?
So definitely becoming more common. Studies have shown prevalence, incidence definitely increasing. Before it was always thought to be kind of a disease of urbanization, the West, but we are seeing more and more in our kind of developing settings. So South Africa, we don't have really good statistics. IBD Africa working on, we've got a nice database of IBD patients. But they sort of basic stats, about 7 million people worldwide are living with inflammatory bowel disease.
That we know, that they know of. I mean, those are the diagnosed ones, I would imagine, that are aware.
Unfortunately, especially in the developing countries, I mean, South Africa, we are much more fortunate than, the rest of the African countries where they just actually don't have the facilities to make this diagnosis. And also just, unfortunately, the lack of knowledge about these diseases, that IBD does exist. It's not a well-known, not known about. I'm sure Nico didn't know about IBD.
Well, thank goodness we have doctors like you, Dr. Kahn, who are so with it and and amazing. So let's talk healing now. And this term I've come across, it's new for me, mucosal healing, and that's become a core focus in managing IBD. What exactly is it? Let's talk about that because it's very important in a patient's treatment journey. Let's without the technicalities for us laymen and women, please.
So I'm going to try and keep it basic. But say in essence, say I get a patient who presents with typical symptoms of bloody diarrhea, abdominal cramps for the past few weeks or past few months. One of the first tests I'm going to do is a scope or a colonoscopy, endoscopy. These are all terms that, there are people out there who haven't actually heard about these procedures. And I think it's good we're talking about it because I'm also going to use this opportunity just to advise that everyone's going to need a colonoscopy in their lifetime.
Yes.
So, it's part of your screening investigations, like women do pap smears, mammograms, men check their prostates. Everyone has to have a screening colonoscopy. And it's now actually, the age has been brought early to 45, is when you have your first screening colonoscopy. And again, the point of this is to pick up precancerous lesions because we are seeing an increased incidence of colon cancers. But back to the actual procedure. So, we do a colonoscopy, which is a scope. And in essence, what it is it's a long tube with a camera at the end. The patient is asleep. It's not a general anesthetic, but we do use an anesthetist to do what we call conscious sedation. So they're just having a lovely deep sleep.
It can be traumatic for
It's
some
not
people. I would
something you want to be
imagine.
awake for. Not
Yes,
something you
no.
want to be awake for.
Yeah.
And this long pipe with a camera, we pass through the anus and we follow the rectum, and we follow it all the way to the end where it meets the last part of the small bowel, which is where, Crohn's disease is more likely to affect the part of the digestive system. So say, example, a patient with ulcerative colitis, I go in, I do the scope, and what I will find is inflammation of the mucosa. So the mucosa is the inner lining of the colon, okay? And we'll see inflammation. When I say inflammation, I refer to redness, ulcers, there can be bleeding, there's loss of the normal vascular pattern, and that's what we call mucosal inflammation, okay? So we've diagnosed, I would take biopsies as well. We send that off to pathologists to have a look at it under a microscope. And that's actually how we make the definitive diagnosis of IBD. And more specifically, we can make the diagnosis most of the time of ulcerative colitis or Crohn's disease more definitively. So we've got the diagnosis, we start the patient on treatment, and then obviously we want to assess how the patient responds to treatment. So in the past, gastroenterologists or doctors would use just symptom resolution as a response to treatment, and that would be it. What the studies have shown over the years and the research is that that's actually not enough. So what we actually want to see is what we call this mucosal healing. So we want to, after a couple of months, do a colonoscopy, and I want to go in and I want to see a healed, normal-looking mucosa. That's mucosal healing. That really is one of the pivotal goals of treating inflammatory bowel disease. I think what's important to know also is, so when we look at the management of patients and what our treatment goals are, we have various goals. So we have what we call the guidelines, which show us various goals. So we have short-term goals. So what we'd like is we want to see symptom response and resolution. So from Nico, I'd want to hear that he's now got normal stools with no blood and no abdominal pain. We also do some blood markers, something called a CRP. I think we'll talk about that a bit more later. But we want to see the blood marker come down to normal levels. So that's kind of your short-term goals, and you want to see that within the first 2 to 3 months. We then get midterm goals, and with that we want to see normalization of another marker called a calprotectin, stool calprotectin. Again, we'll talk about that a bit later. And then our long-term goal is mucosal healing. Along with mucosal healing, we also want the patient to have a normal quality of life, and we don't want any disability, and that we expect actually within 12 months. So as I said, very important goal. And why it is an important goal is because the research studies have shown that in a patient who achieves mucosal healing early on, it improves their long-term prognosis. It decreases their risk of what we call flares, so where the colon will inflame again, and they need short-term treatment. And then we have long-term treatment goals as well with inflammatory bowel disease in patients on treatment. So one of the long-term goals is mucosal healing. So that, is the main topic we're talking about. So why mucosal healing really is pivotal is because the studies and the research over the past years has shown that a patient who has achieved mucosal healing early on has better disease control, so they have less risk of what we call flares. So flares of IBD means recurrence of symptoms. So patients who have achieved mucosal healing have less flares. Just on that note, when patients do have flares with IBD, one of the treatments is steroids, and also recurrent use of steroids in the long term also has its long-term adverse side effects. So patients have better disease control. They have a reduced risk of complications, especially patients with Crohn's disease. Again, reduced risk of complications. One of the big complications, and in patients with ulcerative colitis, is the risk of actually losing your colon. If we don't get on top of the inflammation, we don't achieve mucosal healing, there is always the risk of a surgery where the colon needs to be removed and the patient lives with a stoma. Mucosal healing also improves the patient's quality of life. I'm sure Nico will elaborate more on that. And also studies have shown that when you achieve mucosal healing, it can actually alter the course of the ulcerative colitis.
Okay.
So in general, that really is why mucosal healing is one of the pivotal goals of inflammatory bowel disease.
With the flare-ups, what might cause a flare-up in a patient?
So I think one of the most important things, I think that's a really good question, Uveka, is, so patients who stop taking their medication. So I think Nico and I will talk about this a bit more later, but compliance with one's medication is extremely important.
It's because once we start to feel better, we think, I don't need this
Exactly.
medication now anymore.
Exactly.
And
And that doesn't only happen with IBD, it's lots of
Yes.
other it's another thing that we'll talk about, the relationship between patient and doctor. It's not easy taking medications. They also have their side effects. So patients who stop their medication, again, you've got the risk of what we call flare-ups. Infection can cause flares. Those are probably the most common.
So, Nico, tell me, when it came to mucosal healing, you're obviously now an expert on it, right? But at the time, did you understand what this was, and how was it explained to you? Did you quite get it? I mean, obviously you were dealing with this thing now that was in your body that was happening to you. But when it came to mucosal healing, how did you understand it?
I didn't initially. I had no idea. And then again, with being diagnosed so early and it being completely new, there's so much of information to take in. It becomes so hard to remember what is what. But as you go along the journey and, again, developing a really good relationship with your doctor, you start to ask questions and understand, what is this? What is it going to take for me to get to this stage?
Yeah.
And eventually, you have to be willing to ask questions. And apart from asking questions, you got to also be willing to do your own research, kind of get your own understanding of what is this.
Yeah.
And it goes beyond just a simple Google search, right? So you physically got to go to the websites, the NHS websites that Dr. Kahn directed me to. I spent hours on there trying to understand, what is this? What is it going to take to get to this point? And to Doctor's point, it's not something that you can, hey, I feel great today, I'm going to stop my medication and we're good to go.
Was it a lot of work?
Yeah, absolutely. Understanding it is a lot of work, because it's not just something you can read. It'd be like, like bulb emotion. I understand it now. It's a long process. You got to do a lot of reading, and you got to understand how important your medication is. So it's not like the flu, where it's like, doctor says finish your course, but after 3 days I'm great, I'm going to move on with my life. Not taking it would obviously kind of affect your mucosal healing. So you got to have that consistency. You got to take your medication. You got to get regular checkups, and you slowly start to understand it with time. So don't be upset with yourself if you don't get it. Just be a little patient with yourself, and eventually it will spark.
And make peace with the colonoscopy.
I
that
think
you have to do it more than that once is enough, but again and again.
Yeah, but I think it's important, because someone like myself, you're
Yes.
oblivious to these things.
Yeah.
You're going through day-to-day life and you're just living. You don't know what the importance of a colonoscopy is. And for those who don't know about IBD, you wouldn't think it's necessary. But having gone through these things and experiencing it, and obviously when you think back to the trauma that you had from it, it's like, I'll make sure I get it, despite the negative thoughts I may have about it, or the invasion. It's like, no, I got to do this.
You
No,
have
I
to do
have
it to
do
live.
this, to know what's happening. Am I okay? I don't want to kind of have a repeat of what happened before. So you got to just accept it and be okay with it. And I think for me personally, I'm at that point now.
And I just want to know from you, in terms of your lifestyle changes, I mean, taking the medication is one thing. You know that you're a diligent student. I can see that. You're a good patient, right? Dr. Kahn is a good patient.
My model
But-
patient.
model
Thank you.
patient,
Try.
which is why you're here today. But in terms of your lifestyle changes and diet and you were relatively healthy before, but again, what were some of the major things you had to change about yourself
Gosh.
every day?
Steak.
Curries.
Curries.
No curry.
I absolutely I used to love. I would finish, like, for those who don't know, like very, very sauce number 10. I would finish that in a week. I would eat it with everything and anything, and that could be why I love eating strong food. So the lifestyle adjustments was a shocker for me, because there's so much of stuff that I love, and I used to love steak. I would eat steak at least once a week. I loved steak.
And you can't have it anymore?
You can't have
No red meat?
No.
Oh.
At least for me.
Oh.
It's one of the stuff that causes me to have an episode of like a runny tummy, because again, diet is so important. You forget how important what you put in. It obviously plays a role in what comes out, whether it's normal, whether it's consistent, or whether it's like a diarrhea, runny, or whatever. So what I eat now, it's very Mediterranean. I mostly eat chicken. That's like my to-go-to. I can have pastas, and I eat what my body lets me eat.
Okay.
So you got to go through the process of elimination.
It was
You
trial
gotta-
and error for you.
I always laugh, because I think back to when I just got to hospital, and I met Dr. Kahn and Dr. Latimer at the time. I made a joke about a chicken and mayo sandwich. I'm like, I cannot. And doctor's like, okay, we got to go through the process of elimination. Chicken and mayo failed today, but we'll try it again in 2 weeks.
Okay.
So again, that's part of it, is you got to go through the process of elimination.
Yeah.
Figure out, if I eat this today, what the outcome is, and I know, okay, this is okay for me. I don't have any bad effects, no pain, no irritation.
It's a bit of an emotional roller coaster, I would imagine.
It
I
is.
mean, I often think about people on diets, just a normal weight loss diet, and how you're thinking about food all the time, and it freaks you out. I can't imagine what this must have been like for you.
It was horrible again, because when I after the diagnosis and I got released or discharged from hospital, I lost a lot of weight, like almost 32 kilos in my entire that 2-month period.
See, there's a silver lining.
Well, it depends on how you look at it. Of course, I get that, but then you got to figure out what to eat, because then you're so scared again. So you got to break that fear. The moment you get out of hospital, then there's no care or doctors to talk to. It's like, okay, I don't know what to do now. Like, what do I eat? So that you got to get over that initial fear, and it will happen. It's only normal and natural, but you start trying small portions and you figure out what works and what doesn't. Like, I'll give you an example. I used to love peppermint tart as an example, but the cream gives me a reaction. So I got to go through those stages and figure out what works. But once you know what works, then again, that's when you kind of start going in the right track, because you're eating what you can eat and you don't really have symptoms. So it kind of brings a sense of normality, so to speak. But yeah, that's kind of the experience.
I'm sitting here thinking, your poor wife. I mean, she's got to I can't imagine what her shopping list is like, or how it changes,
Just
and
chicken.
Experimenting with you. But I suppose it's life-changing for your entire family. It's, this is so much more than just your colon, thinking about that. But you're eating the way we should be eating anyway, healthily. It's kind of generally very healthy. So, and I can't imagine how much you save not getting takeout. That's great.
Well, on that note, it's going to be different. So some days there will be a time when you can't eat something, but then you try it again in a month or two and then it's fine. Yeah. So again, it's always going to be a process.
And it depends on the healing inside as well, I would imagine. It's all connected in what you can withstand. And I'm no expert, but I'm just trying to picture this. But
you kind of, the big thing is there's lots of talk about anti-inflammatory diets. And really, actually, in children with inflammatory bowel disease, diet is actually the primary treatment. Therapy that we use. So, you want, as I said, avoiding your ultra-processed foods, as clean as possible, which isn't always possible and not always very affordable. But as clean and healthy as you can, as anti-inflammatory a diet as you can manage.
Great. So tell us about those conversations you've had to have now, and why it's important to sort of communicate properly, be clear, not be ashamed, I would imagine, to ask the type of questions you might think, oh, that's a bit personal. I don't know if I actually want to talk to my doctor about what my poop looked like today. I have to look in the bowl also every time. So, how did you approach this when you woke up and saw this gorgeous doctor at your bedside?
It was rough. I mean, the first day I saw Dr. Kahn, I don't even think I took note of Dr. Kahn's face, to be honest with you. I was in my own little... I was out of it. I was completely out of it the day I met Dr. Kahn. But the conversations, so I had to adjust. Unfortunately, my situation was very different than someone else's or other people's, just because where the doctor I initially was with, I had absolutely no idea what was going on. So I didn't know what my diagnosis was. I didn't know what questions to ask. I didn't even know what a gastroenterologist was, to be honest with you. So a lot of it was unknown to me at the time. And then eventually with time, I had to build up the confidence, because I realized, I need to know what's going on. And fortunately for me, I had to just overcome the initial pride of, being afraid or ashamed of asking certain questions. And I felt very comfortable with Dr. Kahn. She was obviously the type of doctor that makes you feel like you can talk or ask about anything. And that's pretty much became like a natural thing. So I asked a lot of questions. I asked everything from what food can I eat. I wasn't afraid to talk about the consistency of my stool anymore. And because I started to realize that I need these answers to know whether I'm on the right track or not, because again, this diagnosis is confusing. It's very, very, it hits you in a very soft spot, because it's a lot to take in initially. So to kind of come to terms with what's happening, it is. But to kind of understand, where I'm at, what I need to do, I'm not going to get that answers on Google. I need to talk to my doctor. And that's when I started becoming more forthcoming with Dr. Kahn and kind of asking a lot of these questions. And Dr. Kahn has made me feel very, very comfortable with my diagnosis and with my, my treatment and what's going to look like. They've assisted with a lot of it. getting things prepared for me, helping with medication approvals, etc. So it's been great developing that type of relationship. Yeah.
So she's become your new bestie.
Basically,
your new BFF forever. And Doc, I mean,
Till the end.
you've also got to play therapist here because it's physical, which that is, I mean, you could do in your sleep, but you've also got to take them through the emotional side of this. It's a very emotional thing.
No, so, that's a really important point. So I think Nico and I really did meet when Nico was kind of almost on death's door, and he was at high risk of losing his colon. So, from the because his inflammation was that bad. And unfortunately, his experience with, previous healthcare providers was suboptimal, which happens. But when Nick and I met, as I say, very sick, his inflammation was very severe. Initially, we were struggling to get on top of the inflammation. Yeah. And in my experience, the patient-doctor relationship, and it's not just in gastroenterology, but really in any consultation, and especially in chronic diseases, it really is important for both of us. So from my point, I know what's happening with the patient, what's going on, how it's affecting his or her life, and it's developing a really open, trusting, judgment-free environment. What I really enjoyed about Nico, and which I love with patients, is patients who ask. Ask
I mean, there's no stupid question.
There is no stupid question. And I think for me, important, as I say, so creating that kind of relationship where he feels free and comfortable just to ask me any question. We talk about poop like it's a meal.
Like it's normal for us.
But it's something we've got to get comfortable with talking about, because these are questions that I will ask at every consultation. So as I say, that first meeting with Nico in hospital, he was admitted for a few weeks. He was scared. He had had a horrible experience with the healthcare system prior to his admission with me. So it's really just going on the journey with your patient. So, talking him through it, talking about those difficult questions like the risk of losing your colon, needing surgery. And it's very important for us to get that relationship so that we really are a team in decision making on what the next step is, what are the treatment goals. And he's, he knows. I think it's good to have a relationship where he knows he can send me an email at any time. I usually hope I do call him back within a couple of years.
I'm imagining the WhatsApp conversations, and all I see is the poop emoji in it all the time. I can just imagine.
You've got to make it light. You have to make it light.
Yeah, you got to make light of a tough situation.
Absolutely, sure. And I think also that helps in or we'll be talking about all about dopamine and this and that, and if you make light and you're laughing about it, you kind of feel better about it. It's all kind of holistic, I would imagine. You spoke about losing his colon. Does that happen with IBD? I mean, worst case scenario, I would imagine.
It happens. So more so with, let's talk about it more so with ulcerative colitis. As I mentioned before, ulcerative colitis affects only the colon, whereas Crohn's disease, mainly the small bowel, but can also have a colitis, which is inflammation of the colon. But we'll focus on Nico and ulcerative colitis. So ulcerative colitis can affect, it's continuous inflammation of the colon, anything from just the bottom part, which is the rectum, but it really varies in its extent to involving the entire colon, which was Nico's situation. And you can get very slight mild inflammation to really severe marked inflammation where the colon is just really sick. And there is, with what Nico's presentation, which we call a kind of acute severe ulcerative colitis episode, there's a very high risk of losing your colon. And it's just because of that severe inflammation. And this is also, I'm sure Nico appreciated, where we get the surgeons involved quite early on, where you have those uncomfortable discussions. We get the nurses, the IBD nurses involved early on. But Nico was lucky, and we're doing good, and I hope we keep it that way.
So you got to that point because, he's a good patient. He took his medication. He, the food, the diet. What was it that saved the colon?
So it was during that admission, we used quite a strong drug. It's a class of drugs called biologics. And essentially it is a drug that, so when patients present with an acute severe ulcerative colitis, the first drug of choice are steroids.
Yeah.
They all patients get steroids intravenously, and you hope that that's going to settle the inflammation. That's not always the case, and it wasn't the case with Nico. He did not, unfortunately, settle with the intravenous steroids, and that's why we need to step up quickly. And we've got as I said, this class of drugs called biologics, which are strong. When they work well. And Nico had a great response to it, and in essence, with the biologic, we managed to save his colon, and he avoided a removal of the colon. Yeah.
So glad you did. Yeah.
Tell me about it. It was actually the 2 days before the surgery when Dr. Kahn rechecked to see that it's working. Oh, the day before actually when we confirmed, because I had my surgery set
to remove it.
Yeah, the doctors were like, okay, Nico, like it's been too many days and the inflammation's not coming down. And I don't want to explain to you, between the pain and the emotional stress and trauma, it was, I don't, you know, it was crazy. And I was actually sitting with my wife, and I'm like, I started getting emotional, and I'm not that guy that will sit and let a tear come down his eyes. No. So, and that kind of changed everything. It was like quite a traumatic experience, but because it became my reality.
So this really it changed who you are, this whole thing.
Yeah, this is going to happen.
Yeah.
This is going to happen. And obviously, again, quick action from Dr. Kahn, and obviously being in the right place at the right time, fortunately, kind of made it so that it didn't happen.
Thank goodness.
I'm grateful, and I'm hopeful that it's going to remain that way for the rest of the days. So
I have no doubt. I mean, you are, like we said, a model patient, so you have to have regular checks. How often does he have to see you?
So it all depends on, as we say, when I first see a patient with a new diagnosis of inflammatory bowel disease, I also see a lot of patients who have had their diagnosis for short term or for years. So it depends on what we call their disease phenotype. So just how severe the inflammation is, the extent of the digestive tract that it involves. But let's take Nico's case, for example. He had the most severe form of ulcerative colitis. It was really touch and go. So when he was discharged from hospital, I think I saw him the next week. And probably 2 weeks again after that. So it can be anything initially from, every couple of weeks, and eventually our visits, depending again on his response, will become every couple of months. Eventually, once we really have good disease control, it's, I like to see patients at least twice a year. But again, it depends on, each consultation, each step. So it's really taking it a day by day.
And does he have to do anything in particular, any tests, bloods, or do a colonoscopy before he comes to you? How does that work?
Yes. So that's important. So I think patients with inflammatory bowel disease, once you've had it, you become quite well versed with all the tests. But so before Nico comes to see me, there are a few tests. We do some blood tests. So it's something I mentioned before. It's called a CRP, a C-reactive protein, and it's an inflammatory marker. It's a blood test. And, I usually expect his bloods to be done. So CRP would be one of the tests. We also look at hemoglobin, which are your red cells. Remember, if you're bleeding from your colon, you can lose blood, so you could be anemic. And then a few other blood tests we do, because all medications have side effects. So, some of the side effects of medications that patients with IBD take, it can affect your liver, your kidney, your red cells. So those are the basic blood tests we do as well. Then there's also a stool test we do, Nico knows well. It's called a stool calprotectin. And what this shows is if you've got any inflammation of the colon, if you've got a colitis. So what's nice about this test is it's a non-invasive test. So you provide a stool sample in a little jar. It goes.
That must be fun.
No.
You experiment.
You get used to it, though.
As I said, nice non-invasive test of monitoring where we are. So, for example, when Nico first saw me, his calprotectin was over 3,000. We instituted treatment, and a few months later, it came down to a couple of hundred. But I want that to come down even more. So those are they're blood tests we do, they're stool tests we do. I may ask for some cross-sectional imaging, also very important in patients with inflammatory bowel disease. So your cross-sectional imaging, that would be your CT scans, your MRIs. So they're radiological tests that we do. And we can also get a nice idea of, they can see inflammation to a certain point in the bowel. So those are also tests we do to monitor disease progression or resolution.
Okay.
With regards to the scopes, so as we said before, patients with IBD do need regular colonoscopies. And again, all depends on the extent of the disease.
It sounds
symptom
it sounds like a
control.
lot. I mean,
It
Nico,
is a lot.
let's say, for example, somebody's just been diagnosed with IBD and they're listening to this,
Yeah.
and they go, "Goodness, just take me now, Lord," because of all of the stuff I have to go through. How do you cope? Give us some tips on how you prepare yourself to go through all of this, and and why it's worth it.
Yeah,
I mean,
it's-
you're alive,
Yeah, of course,
Yeah.
exactly. It's my life.
Yeah.
But I felt exactly like you just said, Lord, take me. I was like, initially, you feel like that. It's very daunting. It's like, I don't know what to do. I don't know. I have no idea what's going on. But you get used to it. The pieces fall into place with time. So you have to, if you're newly diagnosed, the one thing I didn't have was patience. I really just wanted to know what was going on. And unfortunately, in the initial stages before I got moved to Dr. Kahn, it was sucked. So for me, the first thing I would do is make sure I'm at the right place. Make sure I understand what this diagnosis is, right? So do your research, or have someone, if you can't do it for yourself, just speak to your partner, your parents, or someone that's close to you at the time, and be like, help me understand this. You got to be willing to be open, and obviously be a little accepting of the fact that this is happening to you. And right now, what you do next and how you react and the questions you ask and the amount of information you get is going to be important. So for me, those are the stages. You go through stages of emotions with this, right? So it starts off very, very traumatizing.
Overwhelming, I would
Overwhelming.
imagine, yeah.
And you don't open up to people. You don't want to see people because you have no idea what's going on yourself. So how do I sit and have a conversation about something that I don't know?
Yeah.
So you go through those stages, and I think being in front of the right medical team is going to be even more vital, because they kind of put that into place for you.
That's a very important point
Yeah.
you made there. I want to pick up on that, is people around you.
Yeah.
And, kind of explaining. I mean, you get invited to dinner, you get invited to things, explaining exactly now what they need to do for you, how they need to accommodate you. And do people really understand, or do you just, it's just a bunch of poop jokes that come up? I mean, we're joking about it here because, the doc gave us permission. She spoke about it first. So, do you feel sort of like people really don't understand it, or you've started to educate people around you?
I actually started to educate people around it just for my benefit. Like the people I'm around often, it's because they don't know, and they won't know unless you tell them, right? So you got to be willing to open up about it, and that's something I had to get over as well, because I'm not a person that likes to talk about health issues or being sick or anything like that. That's not my to-go-to. But again, you got to learn to adjust. And again, this is your reality, so you got to be willing to share this with people around you. And I think it's important, like, whether it's your parents, your colleagues, or your friends, be open and upfront. Hey guys, to be honest with you, these are the things I can't indulge in right now, and these are the things I can't, so that at the end of the day, these people also can cater for you when needed.
Yeah.
I think that's very vital, because you don't want to be sitting around a group of people having a meal and you can't eat anything that's on the table.
Yeah.
As an example, that's a reality also.
And I mean, and I know this is difficult to talk about, but and I joked about your poor wife earlier, talking about how she has to probably cater for your diet. But I would imagine, in terms of a marriage, this might put strain on it. Intimacy, if you're happy to share some of that with us, what it does when you are living with something like IBD and you're going through all the treatment. You've got kids, you have to be daddy still. I'm just curious to know how it affected your life in that way.
A lot. Again, everything when we talk about IBD, there's an adjustment. You got to adjust something in your life to cater for this disease right now. When it comes to my family life, yes, I'm lucky enough and blessed enough to have a very accommodating wife. So she will obviously do what she needs to do from a meal perspective. She makes sure I'm taken care of. She also doesn't like it when I'm losing a lot of weight. She wants to make sure that I'm on a straight path. So that's great. When it comes to being a dad, initially it was very, very hard. The moment I got home, I had lost a lot of weight. And one of the biggest things or symptoms with IBD is the fatigue. So I couldn't lift up my daughter for the first month and a half of being at home. So the entire December into January, I couldn't hold her. She couldn't be on me because everything was very real in the abdominal area. It was very painful because, Dr. Kahn can remember, I laid in hospital for my entire visit there with the pillow over my tummy so that no one touches it. Like, you couldn't do anything with it. There's no intimacy in your life at all because you can't. The areas that require it don't work. Yeah, it really didn't. So I think there was a massive lack of testosterone, massive lack of iron or whatever, and there was nothing for the first 3 to 4 months. Nothing, absolutely nothing. So you got to get used to that. And fortunately, if you're lucky enough and you have people around you that understand, or your partner understands, it becomes helpful, because then you don't sit and become very self-conscious about it and, cause yourself to go into a very bad mental state, because I was in one.
I can only imagine.
Yeah.
I mean, and very quickly for us, after everything, Dr. Kahn has explained in terms of your checkups and preparing, I'd imagine the finances take quite a knock as well.
100%. It's not cheap.
Did you have to sell that car that you bought for your wife that day?
I'm thankful to God that no, I didn't.
Okay.
But it does become hard. If you're lucky enough, you have a good medical aid, and apart from that, we've been blessed. I've been blessed in a position where I wasn't too far behind, and the hospitals are very accommodating. You can make plans and stuff. So, but the reality is, it's very expensive.
Yeah.
The medication that you got to be on, there's daily meds that you got to take every single day of your life. It becomes taxing, but with time you realize that you can't be without these things, so you got to find a way to make it fit in your lifestyle.
Have you become
budget.
a pill box guy? Have you got the...
Oh, we joke, but I do.
Yeah.
I really do. I literally have my Monday to Sunday one, and I fill it in every week.
Yeah.
Model patient.
Patient. I say get the kids to do it for you. Get the kids. Get them involved. Give them some work to do.
I
they
do.
Can fill your
Shame.
pills,
My kids have been very accommodating, and I think again, what's really beneficial for somebody that's newly diagnosed is having a great support structure.
Yeah.
I think it helps, because you'll find that in your initial early stages, there's a lot of things you can't do for yourself. To put it into perspective, I couldn't walk.
Yeah.
And Dr. Kahn used to force me to walk. I couldn't walk. Between the pain, fatigue, and I have no energy, I couldn't. I had to hold on to my wife and take small steps at a time. So support structure is important. Medication is important. I think that those are vital things. And if you don't have a support structure, not everyone is fortunate enough to have kids at home or to have a partner in their lives. You just really got to have your own willpower and your willingness to want to make yourself feel better and do better. And with a strong mental state, or trying to develop a strong mental state, it becomes possible.
So, Doc, I mean, when patients come to you, you are their go-to person. You are kind of like their savior. You have all the answers for them. So, what are the things that are top of mind when you're giving them advice, when you have to guide them on this journey? It's a big responsibility.
So, I mean, as you can all see, Nico's a model patient. Not all patients are as easy and disciplined as Nico. And you've got to be, so number one is kind of compassion and empathy and understanding, that these patients are living with a chronic disease that's going to be with them for the rest of their life. And we aren't sure what the course is going to be like. We can only hope that it's going to go from good to better. And as we said, it's having a open, trusting relationship where Nico can talk to me about anything, ask me questions, and it's a regular check-ins. It's talking about anything from his symptoms to how it affects his quality of life, his relationships, his work. As you mentioned, fatigue is a big thing.
I would imagine depression also. The chances of depression are very higher.
So the link between depression, anxiety in patients who live with IBD, especially those that aren't controlled, is quite high. Nico's got a very positive mindset.
He does,
which is really beneficial in, I think, any disease process. But I think that's important. It's he makes my job easy. We talk. I've got a good relationship with him and his wife. We've gotten to know each other, and it's just a constant working relationship.
Did you tell it's okay for her to have a steak, even though he can't? It's fine. She can have a chop and a steak.
She wouldn't, though.
She wouldn't.
No,
he's lucky. He's very lucky.
I am blessed. But
Yes.
it's nice. It's. I would force her actually when we're doing grocery shopping. I'm like, you don't have to not buy this because of me. She's like, but then I've got to make 2 pots of food.
She can have it on girls' night out. It's okay. That's fine.
That's what we kind of discuss. Is when she goes out,
fantastic.
she can eat whatever she wants.
Yeah, that's fantastic. So she also has something to look forward to after that. So Nico, having gone through this journey, if somebody is sitting, like I said, listening to this for the first time, they've been diagnosed, what would be the one piece of advice you'd give them? This is the start of their journey. How would you encourage them? Don't give up now, and especially all the stuff that's involved. This is life-changing.
I think the first thing I would want to do, which is one thing I wish I'd done initially, is make sure I'm in front of the right people. Make sure you're in front of the right medical team who know exactly what they're doing, who understand what it is that you're going through, to make things a lot easier for you. And trust the process is very important. You got to be willing to trust the process and go through the highs and go through the lows. It's not going to be easy. That's just the reality. It's not going to be easy. And once you make peace with that, then things slowly start getting better because you know why you're doing the things you got to do. You got to get used to needles. You got to get used to pulling bloods. You got to get used to scans. You got to get used to maybe being pushed around in a wheelchair because you can't walk. And it's all going to be your reality. And once you understand and accept that it's your reality, that's the moment things kind of the picture gets a little bit more clear for you. So realize and understand that it's going to be hard. That's core number one, but also have the willingness in you to go through the tough times and come out on the other side. To me, because we talk about having a positive attitude and a positive mindset, and the reality is for me, it's that it didn't just happen today. I had to gear myself up into having this mindset because, to Dr. Kahn's point and yours, is you go through a depression, you're gonna get sad, and it's gonna suck for a while.
Relationships are gonna get hard.
Relationships are gonna get hard. So being around a good support structure is important. Or build your own support structure. Be your own support structure. Because again, I do that for myself as well. And you can look at it from two ways. I can sulk about it for the rest of my life and hate it and just be like, gosh, why me every single day of my life? Or I can just put the fact that I've managed to, for me, for example, I managed to keep my colon intact, which is a very positive sign. I'm able to get up every day. I'm still able to go to work despite the restrictions that I have and despite the things I can and can't do. I'm still here. I get to be around my children. I get to be a dad. I get to be a husband. And so that for me is very important. And so then I realize, oh, okay, I got to do all these things to ensure I keep doing the things that I love doing, which is, again, being a general person that takes care of his family, being the guy that can be there and support his children. And that's why I choose to have the mindset that I have. It's my choice. I choose to do this so that I don't have anything holding me down, but rather I'm consistently uplifting myself. And that's going to be very important. Don't allow it to get to you. Don't allow it to put you in a negative mindset. With the moment you sit and realize that you're going down a very dark path, which happens to me a lot because of how my journey started with the previous healthcare provider, it traumatized me. And so I found myself doing that a lot, like just keep replaying what happened before I landed in front of Dr. Kahn. And it's like, no, I got to give myself a reality check and be like, get out of that mindset. Like, dude, you got to get out of that mindset and you got to start really focusing on the positive because you're sitting in front of your kids.
Yes.
And I can't allow my children to see that, hey, dad's not looking great today. You want to be that strong point. And again, it's okay to not be great on a particular day, but you don't want them to worry about you. You don't want them to think something might happen tomorrow.
And to be anxious all the time, I would imagine.
Yeah,
about
100%. I'll keep the anxiety to myself. That's one thing you also got to get used to, is just being, again, your own support structure and go through your things in private and then talk to your doctor.
But go through them. Don't deny them is important, yeah?
100%. You are so correct. Go through them. Yeah. You going through a trauma, take a moment for yourself, because I do it a lot. I'll just take a moment where I'll just jump in my car and I'll just take a drive. Wife is like, you're going to go take a drive? I'm like, I'm going to go take a drive. I'm going to go play golf. I'm just going to get on the golf course. I just want to get away so I can just go deal with and process whatever emotions that are bad that I'm going through right now. And I'll come back because I don't want to put that on everyone else around me. So again, going through these and developing this, we want to call it emotional maturity. Is what I would call it. It doesn't happen overnight. It will take a few months, but once you get to that point, you'd be a happy person living with IBD.
I'm having a yes we can moment.
Yes we can.
Yes we can moment. And Doc, from your side, you're the person, like we said, on the other end of this. You form part of that support structure, a very important part of that support structure. What is the main takeaway from or the giveaway for you in this conversation?
So I think importantly, just firstly, awareness about inflammatory bowel disease. It is more common. So being aware about what the symptoms are, when to seek help. And then I think what's important just in general with any chronic disease, you need to find a healthcare provider that you're comfortable with. And sometimes that does involve shopping around. Don't be afraid to do that, but find someone, because this is going to be a journey the two of you are going to be on for life. So find someone that you feel safe with, that you get the support you need from, that listens to you, and in general you feel comfortable with. Also, I think it's important to know IBD with modern medicine now, the prognosis, the outcomes really have improved. You can, with the new medications, people with IBD can live a really full, productive life.
Absolutely.
Yeah.
like this, like Nico.
Exactly.
Yeah, we're getting there.
Yeah.
We're
Well,
getting
wonderful, wonderful. Thank you so much for sharing
Oh, it's been
and your time and Nico sharing a lot more.
Yeah.
Than I expected you to as well about your journey. Thank you. And wow, we've covered a lot. I've learned a lot today. First, I learned what IBD is, and more importantly, mucosal healing and why it is so pivotal and why it is so important in this entire process of healing and managing IBD as well. And just a powerful reminder, I think, that this is a journey. It is a lifelong journey. It's not the end of the world. It doesn't mean it ends your life, but it is a lifelong journey. And from what I see, a healthier way of living, actually the way we all should be living and eating and managing our lives as well. And just how important the support system is, like Nico told us. And also, Doc, like you said, don't feel scared. Don't be ashamed to ask any question. There's nothing you haven't heard. You've heard it all, okay?
Exactly.
Yeah. You've heard it all. And there's no question that's a stupid question. This is your journey. This is your life. This is your body. And it's important to know your body and know yourself more than ever before and to watch out for this. It's the biggest investment is yourself.
Yeah.
If you can't take care of yourself, how are you going to take care of those that love you and those that you love as well? So important. So whether you're at the start of this IBD journey, whether you're in the middle or whether you're at the end, I think this information that we've passed on today is actually so important to everybody. And when I say the end, I don't mean you're dying from it. I mean, you've come to terms with it. You're there now, like you are. You're managing it. You know what you're doing. But again, always be aware of your body. I think do the checkups. Don't take the shortcuts. Take your medication. And just because you're feeling better doesn't mean that you stop that process. You keep going. Thank you so much, Dr. Thania Kahn. Nico Dhevnanan, thank you very much for sharing your journey with us. And I wish you all the best. And I can just see that you're going to be the best ambassador for IBD going forward. The poster child for IBD. I've learned so much. And if you are listening to this podcast, please do share it with everyone. It's not just about IBD. It's about any chronic illness. A lot of this information applies to anybody who is dealing with some kind of chronic illness. So share it. And most importantly, keep the conversation going. Keep talking, and sharing. Thank you so much for your time.